Hi, everyone. Welcome to the second session of the Operation Reproductive Health webinar series sponsored by Walgreens. Today, we'll be talking about women's health and covering perimenopause and menopause. So we'll start off by introducing Dr. Lally Havern, who is our contact over at Walgreens, and she'll share information about Walgreens and how you can get involved.
Thank you so much, Parth. Good evening, everybody. I just wanted to get on right before Dr. Vernon's lecture and just say a quick few words about Walgreens. So as Parth said, my name is Dr. Lally Havern. I am a proud graduate of the University of Pittsburgh and Duquesne University School of Pharmacy. And my career at Walgreens has been a long one. I've been at Walgreens for 26 years. I started as a technician and sort of worked my way up in different roles that our company has. In my current role, I am a director in clinical pharmacy strategy, and I lead oncology and sexual and reproductive wellness. And basically, that means I do all of the strategy for our clinical products, like prescribing contraception, for example, or our fertility services, all the way through from first period to last period. So really excited for you guys to learn about a session of women's health in perimenopause and menopause. And then also wanted to give a shout out to our session at APHA annual meeting this year. So it is going to be on March 28th from 1 to 2, and it is part of the Operation Reproductive Health. But basically what I've done is I've gathered a lot of pharmacists from our company and have them talk about what it is that they do to impact women's health. So you're going to hear from people in pharmacy affairs, in regulatory. So when it comes to things like prescribing contraception or dispensing mifepristone, you're going to kind of hear soup to nuts, like how that happened, how we worked with regulations and legislation on getting that passed and how it's going. And so I hope that if you come to APHA annual meeting, you stop by our session, feel free to link me in if you're more interested in our career paths at Walgreens. And before I turn it over to Dr. Vernon, if we could just switch one slide. So outside of reproductive health, I get a question all the time about what type of roles there are at Walgreens. I'm sure everyone's familiar with the community pharmacist role, but there are other roles if you're interested outside of community pharmacy. And so here what we've done is, because I've been at the company for so long, I was actually able to reach out to a pharmacist in each of these departments and ask them what it is that they do. And so this is actually an interactive website that I can put in the chat if you're interested. And you can go ahead and click on, for example, you can look at pharma trade, and then you'll learn what our team does on the pharma side and how they're sort of the liaison between Walgreens and our pharma trade partner in the specialty business. And so it's really a cool icon here if you wanted to learn more about different roles outside of community pharmacy. And so with that, I will turn it back to, is it Parth, or I can introduce Dr. Vernon?
Yeah, we can introduce Dr. Vernon, but I can kind of just shoot that off. So thank you, Lally. Hello, everyone. So as you've all kind of seen in some of our bios we sent out, we have Dr. Veronica Vernon, who will be presenting to you today. She is a professor over at Butler University and very involved with APJ ASP, so you may recognize her. So without further ado, I'll pass it over to Dr. Vernon.
Hello, everyone. Good evening, good afternoon, depending on where in the country you're from. I like seeing the chat. I will apologize for my voice. My students say I sound like Roz from Monsters Inc. I'm sounding a little bit better now. I am getting over bronchitis, though, but I wanted to be here with you and didn't want to miss this. Who's going to annual meeting? Anyone going to annual meeting? You can do raise a hand. You can do an emoji. You can put it in the chat. Anyone planning on going? I know at least one of you is, because I know I'll see you there because I talked to this person about going. Anyone going, yay, Sean, thank you for raising your hand. Yay. Wonderful. Well, I will be annual meeting. I'm very excited. I'm trying to count how many annual meetings I've been going to. I believe this is my 17th or 18th annual meeting in a row. So I'm very excited. I started going as a student pharmacist, second year professional student at Purdue University. And now I continue to go as a not so new practitioner. I'm no longer a new practitioner. I guess I'm a seasoned practitioner now, but I will be helping out with the Student House of Delegates, which is my favorite part of the student programming, but you should definitely go to everything. I am a certified menopause practitioner through the Menopause Society. That's what that MSCP means, and all that alphabet soup after my name. I actually provided perimenopause and menopause services at the VA in Indianapolis, Indiana, where I had full prescriptive authority. I saw patients for all sorts of menopause related conditions. I helped with their cardiovascular health. I helped with osteoporosis. And then I also prescribed things like hormone therapy and therapies for vaginal concerns during the menopause transition. So I'm excited to talk to you about this. I hope you'll be really active in the chat and be brave and step outside of your comfort zone. My only disclosure is I serve on a pharmacy and therapeutics committee for CareSource. So I read a bunch of drug monographs and tell CareSource what I think should be on formulary and what shouldn't be on formulary, but I do not think it will influence my ability to deliver this presentation today. We're going to talk about the impact of menopause on individuals that are in the healthcare system, and then your role and the role of a pharmacist, as well as evidence-based treatment options and communication strategies. And you're going to spend some time in some breakout rooms coming up with some plans for APHA ASP Operation Reproductive Health by the end of the night. In the chat, you can also private message me if you feel more comfortable. What words come to mind when you hear menopause? We're going to play a little bit of word association. Any word that comes to mind. When I say menopause, you think vasomotor symptoms. Claire, you can tell Claire had me in class. Hormones, absolutely. What else? Any descriptors? Any adjectives come to mind? Claire's onto it with her vasomotor symptoms. Dryness, absolutely, Jessica, yes. What else? Misery, yes, Lolly. I'm feeling I was just standing with a bunch of faculty members, and we are all at a certain time in our lives, and we were talking about just how uncomfortable this period is. Hot flashes, absolutely hot. Just hot is a good word to describe this. You're just hot all the time. I remember asking a patient, how many hot flashes a day do you have? And she said, honey, I don't have hot flashes. I just have one big hot flash that lasts from the time I wake up all through the night. It's just one big hot flash. I'm never cool. So absolutely. It can be a scary time for people as well, this transition. You feel like you're getting older. If we think back to the history of menopause, it was seen as the end of meaningful life for women. So if you think back to ancient Greece, we didn't actually have a lot of writings on menopause because women who reached the age of menopause were considered quite seasoned for that time of life. They were quite advanced in years. If you made it until your 40s or 50s, you were doing really well in some parts of history. And so there actually aren't a lot of writings in history about what happened to people when they went through menopause, which is really unfortunate. And there was a French text that called menopause climacteric, which means something a little different now. But when it was used in this text, it was called the end of meaningful life, which is so disappointing. That menopause has had such a stigma for so many years, and we haven't wanted to talk about it. But when you think about it, about 50% of the population is going to go through menopause. So it's important that we talk about it. How confident are you? Think about this, and then I'm going to have a polling question. Are you talking to a family member, a friend, a patient about perimenopause or menopause? Think about it. And now if you want to, you can respond on the poll everywhere. You can scan the QR code, or you can go to pollev.com/Veronica Vernon and then text your response using the letter to the number is 22333. That's the number you're going to text. Or you can put it in the chat. Have any of you tried to talk about menopause with anyone, including a standardized patient? Maybe you had an OSCE, a standardized patient in lab. Okay, good. No one is in the help category. It's okay if you are. Not confident is all right. Somewhat confident. One of you is really confident. I love this. That's excellent. Share your wisdom. This is a good place to start from. This is not something I was comfortable with as a student pharmacist. This is when I was sitting in clinic as a PGY2 resident at the VA. I was starting gynecology pharmacy services. Our gynecologist looked at me and he says, hey, do you know anything about menopause? Do you want to start seeing patients for menopause? And I said, sure, if you'll teach me, because I think I had maybe a 15-minute lecture on it in pharmacy school. I didn't remember it. And so our gynecologist gave me some good resources, got me started. I connected with some other pharmacists across the country that were doing menopause care. And then that became the bulk of my practice. So sometimes you just have to say yes to things. So we're going to do a Kahoot. This is what my students love to do. So just bear with me while I flip my screens here. and get this over so we can play a game. My students love playing Kahoots, so I thought you might all like playing a Kahoot as well. I'm going to go ahead and get it open, and I feel like we're going to want the music. My students like the music. My 10-year-old was very excited when I told him we were playing a Kahoot game. He was not so excited about the topic, but he did play this. He played this and tested it out for me. So he knows a lot about menopause. So there's the Kahoot. The game pin is 9165039. So feel free to join. You can use a nickname that's not your real name, just whatever you'd like it to be. Just remember this is being recorded. And everybody wins. This is like, whose line is it anyway? If you've ever watched that show, I'm showing my age, but like everybody's a winner, regardless of what the podium says. So let's get started now. It's a short Kahoot. This is a select all that apply. What symptoms may one experience in perimenopause or menopause? So what symptoms do you think? Hot flashes, night sweats, genitourinary syndrome of menopause, depression, weight gain, brain fog, migraines. What do we think? Excellent. You're all superstars. All of these can happen. Hot flashes and night sweats are one of our hallmark symptoms. Genitourinary syndrome of menopause, all of you were right on that. That is the umbrella term that talks about sexual, urinary, and vaginal symptoms, or vulvovaginal. So, including the vulva, which is the external part, vagina is on the inside. And that is a very large portion of what I used to talk to my patients about that actually is not treated well. Only about 25% of patients get treated for genitourinary syndrome of menopause. It's a great role for a pharmacist to talk to patients about because patients sometimes tell us things that they won't tell other practitioners. All right, true or false? Perimenopause lasts for only about 1 to 2 years on average. Good, I didn't fool you. That's false. On average, it's about 4 years. I would say it's much longer than that, 7, 10 years even. And so this is before that final menstrual period. That's what menopause is actually defined as. So if you have a patient in their late 30s, mid to late 30s, talking about hot flashes and night sweats, it's probably perimenopause. And this is something that we see. This is the topic of a lot of dinner conversations that we're seeing now with women in their late 30s, early 40s. It's perimenopause. It's all over social media right now. Approximately what percentage of people experience vasomotor symptoms during the menopause transition? So this is from perimenopause all the way through several years past that final menstrual period. 15, 30, 50, 80. This is tricky. What do I pick? Good. Most of you got it 80%. Most people are going to have a hot flash. Most people are going to have night sweats. This is very, very, very common. So the question you should be asking yourself is, do all of those people get treatment either with pharmacological or non-pharmacological approaches? And the answer is no, they do not. Last question. Besides humans, what's one other species that goes through menopause? Dogs, cats, orcas, or turtles? It's orcas. There's also another type of I know orcas are more of a dolphin, but there's also a type of whale that goes through menopause. We are one of the only species that goes through menopause, though, which I think is really unique. There was a study I just read in a science magazine that they're starting to see orangutans might be going through menopause, and that is actually not something that has previously been seen. Before that, the orangutans didn't go through menopause, but they have adapted over time. It's not amazing. I just think that's amazing. I love those fun menopause trivia facts that really will only serve you if you are on a trivia team, like I like to do. You never know when you're going to get asked about what species go through menopause. I actually did get asked that one night at a trivia question, which is why I threw it in here. So good job. You're all excellent on this. So what's your role? Perimenopause, I think it's important to define, is the time before natural menopause. Menopause is the final menstrual period. How we diagnose this is after 12 consecutive months of no periods. So I always say if somebody's only had 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 months of no periods, we do not say they are postmenopausal yet. You have to wait till 12 consecutive months. My students asked me a few weeks ago when we talked about this in class, what if somebody has had a hysterectomy? They've had their uterus removed. We don't know when they bleed anymore. How do we diagnose it? Great question. We go based off symptoms. We actually don't need to do lab testing. In some cases, we might check follicle stimulating hormone. We may check estradiol. In very rare cases, do I do that? Most of the time, we go off the age of the patient and if they're having symptoms or not. The average age of menopause is 51 to 52. That means some people are going to hit that final menstrual period in their 40s. Some are going to hit it later than 52 when we think about an average age. If individuals hit that final menstrual period before age 40 to 45, that's considered premature menopause or early menopause. They tend to have worse symptoms, which is something to keep in mind. If you just think about the United States, 75 million women in the United States are going to go through menopause. And if you break that down even further, it means 6,000 women every single day are hitting their final menstrual period. 6,000. That's a lot. That is a lot right now. 75% who seek care for their menopause symptoms are left untreated. They're not getting care at all. I had a patient reach out to me, not a patient, I call them a patient. They used to work at Butler. They were a staff member and they emailed me because they knew I did menopause and they wanted some questions and some articles to take to their primary care practitioner to talk about menopause because their practitioner was very resistant to prescribing anything. And this patient was completely miserable. So I coached her through on some things to help her with that. When we think about the symptoms, there's a whole variety. Joint pain is a big one that often gets overlooked. And we're seeing this reported more and more in the literature. I used to see it in clinic. Women report getting a frozen shoulder. So estrogen actually helps lubricate your joints. What happens during menopause when you have that final menstrual period? It's the cessation of ovarian function. Our ovaries are our main producer of estradiol. Estradiol helps keep our joints lubricated. After menopause, we switch over to less potent forms of estrogen that are made in our adipose tissue, like estrone. And so that's why we see some of these symptoms. It's due to the estrogen withdrawal that we're experiencing. If we go on even further, over 13% of individuals report adverse work outcomes. This means missed work, their performance at work is struggling because they're having these symptoms that are bothersome. 13.4% of women that are aged 45 to 60 talked about missing work. And this costs the US $1.8 billion in lost income every single year because it equates to 4.9 million lost days of work among all women who identify as postmenopausal or perimenopausal, which is staggering to me when we think about it. It's not just like a little hot flash. Excuse me, incredibly bothersome. I always like to tell the story of one of my patients. She worked at a men's prison. And so having a hot flash for her was very upsetting because it could be dangerous for her where she worked. She had to keep moving. She had to keep on her guard shift. She couldn't slow down and she couldn't show weakness at her job. And so for her, working with her to find something that she could take that would get her relief at work when she was in her heavy guard uniform, she couldn't take breaks at work, was something that was really important when we think about those social drivers of health. I think primary prevention and proactive care are incredibly important to talk about when we talk about menopause. Why is that? Because 1 in 2 postmenopausal women are going to have an osteoporosis related fracture. 1 in 2. That is shocking to me that once you hit postmenopausal age, your estrogen starts to decline. And then 1 in 2 women over the age of 50 will die from heart disease. Heart disease is the #1 killer of men and of women. A lot of times we have been trained about symptoms with heart attacks that present in men, crushing chest pain, sometimes some arm pain. Women will often experience more subtle signs. So they may have some back pain. It may feel more like indigestion rather than crushing pain. They might have a little bit of jaw pain. They just don't feel quite right. And that is what leads to women dying, is their symptoms aren't seen. So this is education that I go over with all my patients. What are signs of a heart attack? What are all the signs of a heart attack? Not just what we see on TV where somebody grabs their chest and falls over. The risk of stroke for women that are postmenopausal doubles every 10 years, starting at age 55. So the longer you live, the greater your risk is of having a stroke. Half of women that are postmenopausal are going to experience urinary incontinence, which is incredibly bothersome. And then we also see disparities in care. What are these disparities in care? When we look at women who are given referrals for preventative care screenings, we see that there are disparities in those that get referred for bone density screenings, prescriptions for vitamin D and calcium intake, bisphosphonate treatment to treat osteoporosis. And this comes down to women who are of color. So Black women have a lower rate of getting referred to for care than white women. So we do see those social drivers of health play a role in menopause. This is a great role for you to educate your communities on what the preventative screenings are. Some of them that I recommend for all of my patients are cardiovascular risk assessment. Put in the chat, what are some ways that we could help assess a patient's cardiovascular risk? What are some tools you could use or things that you can do as a student pharmacist? Think about your Operation Heart. What do you do? How can you combine some of these other patient care operations together when we talk about menopause? When you think about cardiovascular health, what do we check in patients? Yes, Claire, you can do the ASCVD risk calculator. It is free and you can do it at the pharmacy for the patient. Frequent blood work, you can encourage them to do their LDL, blood pressure, etc. Sometimes you might have access to point of care testing for cholesterol. You might have like a cholestech that's going really old school. That's what we used to drag out to our state fair with my APHA ASP chapter, and we would check everybody's cholesterol and blood glucose, right in the midst of them eating elephant ears. But that's a great way to do it. And you can check blood pressure. Absolutely. And you can encourage your patients to go see someone, a primary care practitioner, get them connected to care in their community. Mammograms aren't something that we offer at the pharmacy, but it's something that you can encourage your patients to get. You could even work maybe with a local pharmacy to host a mammogram, a mobile mammogram that comes to the pharmacy and it can help serve the community. Maybe there's a grant you could work with your community foundation or an organization in your community. Every 1 to 2 years, we recommend mammogram screenings for breast cancer starting at age 40. If anyone has ever smoked, we encourage them to get lung cancer screening starting in their 40s and 50s. Colorectal cancer is on the rise, especially among younger people, unfortunately. And so this is something at pharmacies we can do. If you're in certain parts of the country, you might even be able to provide your patient or prescribe your patient a colorectal cancer screening kit. That's what some pharmacies just to the neighbors to my south in Kentucky are doing to get patients screened. Cervical cancer screening we can recommend starting depends on if you're doing co-testing with HPV and the age of the patient, but every 3 to 5 years. We usually stop this at age 65. And then osteoporosis screening, getting their bone mineral density tested using a DEXA scan. Start that at age 65 or younger if they have certain risk factors. And then you can screen for HIV, hepatitis C, depression, anxiety, substance use, and obviously vaccines. That's something that we can all do. Student pharmacists can do. Pharmacies are known for doing. It's where most adults are getting their vaccines is actually at the pharmacy. So what kind of vaccines do you think about for people that are in their 40s to 60s and 70s and beyond? What kind of vaccines come to mind? Shingles, absolutely. They're over 50. Pneumococcal. Yep. All the Shingrix for everybody, right? Excellent. Is there any vaccine that you might have talked about with Dr. Shaw if you attended his HPV presentation in the fall that might be good for somebody that's in that 40 to 45 age range if you talk to them about it? Gave it away, but it could be an option. Shared clinical decision making. Yeah, Gardasil, the HPV vaccine. That's what Dr. Shaw talked about. He talked about how it has been approved by the FDA for up to age 45. And our recommendation is it's a great discussion to have with your patients. I talk to every single patient 45 and younger in my clinic about getting the HPV vaccine because it can only help, right? We're seeing some countries like Denmark and Australia that are on track to eradicate cervical cancer because their HPV vaccination rate is so high, which I think is awesome. So exciting. As somebody who's family in Australia, I'm very, very, very proud. What can you do for preventative peri and postmenopausal individuals? So type your answer in the chat. You think about your APHA ASP chapter, you think about where you work. Is there one action you think you could take to help improve preventative care? You can think about it for a minute or two. Is there something your chapters already do that you're like, oh, maybe we could start targeting peri and postmenopausal people? We could start doing something for women ages 30 and beyond. I'm good at waiting. I am a faculty member. I'll wait. I'll let you think. Because there's something your chapter does really well that's a patient care operation you're really proud of. And you're like, oh, we could just put out a pamphlet on menopause or have a game, spin the wheel of menopause and learn a menopause fact. Is there something that comes to mind? Yeah, educate peers on how you can support peri and postmenopausal patients. Madeline, gold star for you. Absolutely. Educate your peers. Not all your peers are on this webinar. Encourage them to watch it, encourage them to learn more. How many of you learned about menopause in your curriculum? You've already learned about it. You can raise your hand. You can put out a little emoji. Madeline has, excellent. Isha, women can be on HRT, counsel things to monitor and be aware of risk of stroke. Absolutely. Her says it was very short. Absolutely. A few of you. But it sounds like maybe, oh, you're Jessica, you're doing a research project about it. That's amazing. I would love to hear more about that. Absolutely. There's a lot more work that we can do on this. So when we think about symptom management and best practices, what's the most effective treatment for vasomotor symptoms? I just picked a few. You can respond in the poll or you can respond in the chat. Hormone therapy, venlafaxine, escitalopram, fezolinetant, or elinzanetant, our newest drug on the market. Any other answers? Oh, good. I like that we're getting some variety. The correct answer is going to be hormone therapy. That's going to be our gold standard, our most effective option. These others can be really helpful, and I used, and I always encourage you, use those prime counseling questions when you're talking to patients. They're picking up their prescriptions. What did your prescriber tell you this was for? I made a big mistake as a new pharmacist where somebody was picking up venlafaxine, and I said, "Oh, this is an antidepressant. How's it working for your depression symptoms?" And the patient said, "I'm not using it for depression. I'm using it for menopause." So please learn from my mistakes, and now that's what I do is menopause. So hormone therapy is what we start with, unless they have contraindications. Contraindications could be breast cancer, it could be cardiovascular disease, it could be a variety of things, history of stroke. Those are going to be our big ones. If they have an elevated risk of cardiovascular disease, so their ASCVD risk is getting to be above 10%, about 15%, 20%, we get a little bit nervous about it. But what we do is systemic hormone therapy. So, excuse me, I keep talking more and the coughing gets worse. We will do systemic therapy. So it will hit, excuse me, their whole body. If they don't have a uterus, you can just use estrogen products. If they do have a uterus, we want progestogen on board. Progestogen is the umbrella term for progesterone and progestins. Does anyone know why we need a progestogen on board if they have, excuse me, if they have a uterus? Absolutely clear. I'm so sorry, everyone. Give me just a moment. All right. Sorry, everybody. Excellent. So vaginal hyperplasia, endometrial hyperplasia, excuse me, can occur if we give unopposed estrogen in somebody with a uterus. Estrogen causes growth of the endometrial tissue. Vaginal estrogen, which is a localized low dose, we excuse me, we use for genitourinary syndrome of menopause or those vaginal symptoms. If somebody can't use hormone therapy, we go to SSRIs, escitalopram, paroxetine, fluoxetine, citalopram, all have evidence. Escitalopram is my favorite of that group, or SNRIs, or selective serotonin or norepinephrine reuptake inhibitors. Venlafaxine, desvenlafaxine, and duloxetine. Venlafaxine has excellent evidence in that group. And then our newest drugs, fezolinetant and linzantant, they work on these neurons called candy neurons that target the thermoregulatory center of the brain. And so it's a very novel mechanism. It's very exciting. I like these drugs because they're other tools in our toolbox that we previously didn't have up until a couple of years ago. Gabapentin, clonidine, and oxybutynin could be considered, but does anyone know why, if you've had these drugs before, why these three may not be what we reach for first as a non-hormonal option? Any ideas if you've learned about these drugs? Yeah, Beers list. So they're on the Beers list. We think about 60 and older patients may or may not be getting treated for menopause at this time. They may be, but they have an increased risk of side effects. It's more the side effects. My patients didn't like gabapentin because it caused some edema, some weight gain, made their brain feel foggy. Clonidine causes dry mouth, causes some of those really unpleasant symptoms, some dizziness. And then oxybutynin, when we think of oxybutynin, does anyone know what word we think of to describe oxybutynin? It's an anti. Anyone know? Yeah, incontinence, anticholinergic. So it causes you, it dries you up, helps with incontinence, but it causes dry eyes, dry mouth, constipation. So I never would use it for my patients with menopause symptoms. In our perimenopausal patients, we actually consider hormonal contraception. You could consider something like levonorgestrel intrauterine device if they are perimenopausal to give them protection against unwanted pregnancies, plus a low dose estradiol patch or a tablet. I'm a big fan of estradiol patches for my patients. I use this a lot. We want to use hormonal contraception, though, for patients that are sexually active and at risk of pregnancy. Does anyone know why we recommend that for perimenopausal patients? Any idea? Why don't we just use hormone therapy like we do for our menopause or postmenopausal patients? Why do we need to think about contraception? Yeah, pregnancy, exactly. Pregnancy is a risk until we've had 12 consecutive months of no periods, or there's another reason why they can't get pregnant. This is only for our patients that are sexually active, but I always talk about there's two big spikes in unintended pregnancy: teenagers and individuals that are in their 40s. And it's because they think, oh, I haven't had a period in a few months. I must not be ovulating. That may not be true. So until it's been 12 consecutive months of no periods, we talk about contraception. For other people who may not be sexually active, we use contraception to help regulate their bleeding because it is so irregular during that perimenopausal time. The Menopause Society recommends hormone therapy for women who are 60 years of age or younger, or within 10 years from the onset of menopause, which that would be that final menstrual period. The FDA did approve changes to the labeling for hormone therapies just this month, actually. My students were very excited reading about it. They removed warnings for cardiovascular disease, breast cancer, and probable dementia. These all came out of a large trial that was done in the 90s called the Women's Health Initiative. A lot of issues with that trial. That's a whole other conversation we can have. So it's exciting because the box warnings were removed for some of the things that are on hormone therapy. The risk of endometrial hyperplasia still exists on estrogen products. And this started in November 2025 based off of an FDA review of the scientific literature and many years of consumer groups lobbying the FDA for this. The first batch of 6 products with approved labeling changes already have gone through the FDA approval process. And so we have a systemic combination therapy, an estrogen and progestogen, an estrogen only therapy, a progesterone only therapy, and then topical vaginal estrogen. One thing I say, still take this with a grain of salt. This is my professional opinion. Patients could still be at risk for cardiovascular disease, breast cancer, things like this during the time of menopause. So I still am quite vigilant when they're on hormone therapy, but I think this makes it less scary, and my hope is more accessible to patients. Genitourinary syndrome of menopause. I talked about lubricants with my students for about 20 minutes the other day. We had a lot of fun talking about osmolality. We hadn't talked about that since I think organic chemistry. But vaginal lubricants and vaginal moisturizers are over the counter. This is a great role for a community pharmacist to talk to their patients about. Checking the osmolality of your lubricants and what you recommend. You want something that has less than 1,200 milliosmoles per kilogram, because most of our lubricants are hyperosmolar. So even though they're a lubricant, they are going to draw moisture out of the vagina when they're used. You can also think about things like vaginal estrogen, progesterone, which is DHEA, so it breaks down into estrogen, ospemifene, and then pelvic floor physical therapy. You should always have a pelvic floor physical therapist as your best friend. I was lucky to work with one in clinic, and I was able to refer a lot of patients to her. As a pharmacist, we aren't going to be doing the pelvic floor physical therapy for our patients, but we can educate them on the importance of pelvic floor physical therapists. Everybody, once you get to a certain age, we're all going to need a pelvic floor physical therapist because of the effect of gravity. Everything sinks. And so it's really important to make sure that you're taking care of your pelvic health. It's more than just Kegels. It's not just Kegel exercises that we all learned about in school. What are some good communication practices? Use open-ended questions and be non-judgmental. Start things with like, what health changes have you noticed recently? Or you can say, what concerns do you have? I like this one. I like to check in with all my patients about bone health and heart health as our needs change during the menopause transition. What have you discussed with your healthcare team? What would you like to know? Present menopause as a health topic, not something that's sensitive and we have to whisper about. You want to get the patient in an area where it is somewhat private. But if you feel uncomfortable, your patient's going to feel uncomfortable too. You don't want them to be more confident than you are. It is great to come to a counseling session being humble and ready to learn from your patient, but you should not be nervous about this. If you're looking down, if you are afraid to say the word, do you have any vaginal symptoms? Are you having any vaginal dryness? The patient's probably not going to feel comfortable telling you that. So the more that you can get comfortable with it, the better it is. And this is something that we all should feel comfortable talking to our patients about and educating them. So now we're going to put you in breakout rooms for just about 10 minutes. I want you to design a public health campaign. This doesn't have to be some splashy public health campaign, but what's something you think chapters could do, one step chapters could take to raise awareness about peri and postmenopausal health and the pharmacist and student pharmacist role. So think about, what are you going to do? Where are you going to do this? Do you think, hey, maybe student chapters should partner with their local Walgreens and host a health fair? Who will you partner with? What are some other organizations? We I've seen chapters partner with women's organizations in their communities. They've partnered with women's shelters to help do some clothing drives, but then also provide some education on health topics. So think about it. The sky is the limit here. So I'm going to try to maximize my Zoom skills. I'm just going to do two breakout rooms to allow you to all get, they can come back in.
Yeah.
Sorry, everybody. That's always the problem with breakout rooms. They should have just said leave room, not leave meeting. Well, welcome back. Hopefully, you had a fruitful discussion. Does anyone from the group that came back, do you want to share some ideas that your group talked about? Don't be afraid. I had a major coughing attack in front of all of you. So you should, the bar is very low.
We had some great ideas, so I hope that our students come forward because I was really excited. Like I want to pilot it at Walgreens. So good.
Yay! That's amazing. Share in the chat or feel free to unmute yourself.
So we had an idea for putting together menopause kits. So what I guess the idea of what we'll do is create a kit with just free resources like lubricants. I think we talked about dilators as well, vaginal moisturizers, and including pamphlets to educate women on menopause, perimenopause, and we were thinking we could partner with maybe manufacturers that offer those kinds of resources and really gear it towards women. Just for example, I think we also mentioned like yoga studios, like a lot of women go to those. So trying to find places where we can access a large population of women to give them these free resources, like these menopause kits.
That's amazing. I love that idea. Oh my gosh, please somebody put that into practice. I would love to see it. And partnering with manufacturers was a really good idea, especially of lubricants. There are a few out there. I'm not going to promote any brand, but they have some good ones. And they usually are very willing to work on some materials like this for patients. That's amazing. I love it. And you're giving them something that a lot of people don't feel comfortable talking about and putting it in places where they visit. That's, oh, I love it. Any other ideas?
Our group kind of had the same idea, but less well thought out than that. But we were still going to kind of create kits geared towards women in that age range and partnering with like a mobile clinic that's local or some other public health organization that's local to bring that to patients so that we're eliminating some of those barriers to receiving care.
Oh, and that is still very well thought of, and that's amazing. You're including different partners. I always think like public health departments might be interested in some of this because they do so much outreach in the communities, and sometimes there is some interest in doing some grant-based product projects with schools or colleges of pharmacy and our health departments. But it's a great public health line. Excellent. I love it. Fabulous ideas. Well, we're just going to wrap up. I wanted to leave you with some resources. If you are so excited about menopause now, these are places that I like to go to. I love the Menopause Society. That's my accrediting body for my certification. Pharmacists can take and become a Menopause Society certified menopause practitioner. It's an exam you take. I will say, I think it was easier than the NAPLEX. I am very proud of it. It's something that physician assistants, advanced practice registered nurses, physicians, and pharmacists are all allowed to sit for. And there, last check, we're only about 40 pharmacists in North America, in the US and Canada, that have that designation. For me, why I got it is it was a way to show the VA that I could prescribe and see patients on my own independently. The American College of Obstetricians and Gynecologists has a nice page on menopause. They also have some handouts for patients. I like Let's Talk Menopause because it's geared towards the public, but as a practitioner, I find it really beneficial. And then the Endocrine Society has a lot of support resources for patients, but also for practitioners. Menopause is such a great opportunity, I think, for student pharmacists to talk to patients, especially when we think about all of our patient care projects. It's a great way to have reproductive Operation Reproductive Health partner with a lot of our others. We think about diabetes prevalence going up at this age in a woman's life. We think about cardiovascular disease. So there's a lot of different ways that you can partner with your other groups to create some synergy. You can focus on awareness, getting people to talk about it. What are the symptoms, prevention, and treatment? And remember, every conversation that you have counts. Every conversation, even if it didn't go the way you wanted to, that mattered. And you're getting out and doing the work. You're putting those amazing kits together. You're raising awareness in your communities. So with that, I'll answer any questions you have before we go. I stunned you all into silence. Well, feel
Everyone's
free
like
to reach out
soaking
to
it in.
me if you're soaking it in. If you have any questions or you want to learn more, I love menopause. I have always loved menopause. I remember being a very new practitioner and my patients being like, "Are you sure you know about menopause? You look to be very young." But I think you can use that to your advantage because you don't have any personal experience yet. Some of you may, some of you may not. I don't want to assume ages here. But I think it allows us to be objective when we haven't experienced it and listen to our patients more. Oh, good question. Have I noticed any differences in perimenopause, menopause treatment for transgender men? Absolutely. So sometimes for transgender folks and gender diverse folks that are on testosterone, we actually don't see typically a lot of these menopausal symptoms because they're on testosterone. So even though we're suppressing estrogen, if they've been stable on it for a while, we tend to not see some of these symptoms. But transgender folks can go through menopause, especially our folks that were assigned the female sex at birth. And so sometimes we have to think about what are their goals. Do they want an estrogen based therapy? Will that interfere with their goals of therapy? And so that's just a patient centered conversation that you have. But I worked with some folks like that in our endocrinology clinic that were experiencing menopausal symptoms and were transgender and gender diverse and identified as masculine, excuse me. Caught myself before another coughing fit. Thanks, Claire.
What
Well,
other
feel free to read.
areas,
Go
what other
ahead,
areas of
Jessica.
women's healthcare do you see pharmacists being able to move into in the future?
Everywhere. Dr. Havern can probably talk about this more. I just talked about fertility care today in class, and I was like, this is such a great area for pharmacists to be in, and it is exploding because I think there's been a recognition that pharmacists play such a huge role. A lot of what I did at the VA, we didn't have a reproductive endocrinologist. We had to send our patients out, but I helped manage all the medications. And I gave the example, Fulistin is a pen that we would use for our patients to help them ovulate, especially those undergoing IVF. A lot of practitioners would forget to write for the reusable pen and they would just write for the cartridges or one or the other. And I'd be like, you need both. And with drug shortages and back order and helping patients navigate insurance issues, I had my students go out and find the best price on these 3 infertility meds online and find some patient assistance programs. All great areas for pharmacists to be involved in, but I did endometriosis care. That's another way you can be involved as a pharmacist. Polycystic ovary syndrome, helping with our chronic conditions like diabetes, hypertension, all of that, COPD still impact women. Having a lens as a pharmacist and how I can make this patient-centered care, especially for women, is important. Contraception care, obviously, we're up to nearly 40 states now where pharmacists can prescribe in some respect. That's something that a lot of what my job is now is helping pharmacists do that in Indiana. Pregnancy and lactation support, that was a big part of my job. You are such a resource as a pharmacist. I sit on an advisory board for a local milk bank. So mothers can donate breast milk and we give it to NICU babies, to little tiny premature babies that need mother's milk because formula can cause problems with their gut. And so I help manage all of the medication questions that come in from our mothers who donate. So there's a lot of different ways that you could, like Dr. Havern can probably go on and on. I think there are no limits to what you can do in the gynecology and reproductive health space as a pharmacist.
That's wonderful. Thank you.
Thanks. well, feel free to reach out to me. I'll drop my email in the chat. I will say I am teaching a lot this week and next week, but things slow down once Butler hits spring break in just over a week. But be happy to chat with you.
Thank you all for attending our webinar tonight. And based off of Jessica's questions, a perfect transition to APHA Annual Meeting 2026, where we'll be having a discussion from Dr. Havard and other pharmacists from Walgreens of how you can get into the reproductive health space as a pharmacist, not only from the direct patient care aspects, but also from the regulatory aspects and multiple other areas. So we hope to see you there. This presentation will be posted online. So if you have not been able to catch all of it, or you want to share it with your classmates and your chapter members, please do so. And we would love to see y'all at Annual Meeting 2026. Thank you for joining tonight. Thank you.
Thank you.